December the 12th. Before we do anything with approval of agenda, Mr. Elliott.
Okay, we need to administer the oath of office for the three people who have been reelected. So that is Fred Clark, John Blythe, and Catherine Elconin. So if you three would please raise your right hand and repeat after me. I state your name.
I, John Blythe.
I, Catherine Elconin,
Do solemnly swear or affirm
Solemnly
do
swear
solemnly swear or affirm
that I will support and defend the Constitution
will support and defend the Constitution
of the United States
of the United
and
States
and the Constitution of the State of California
and the Constitution of the State of California
against all enemies, foreign and domestic,
against all enemies, foreign and domestic,
that I will bear true faith and allegiance to the Constitution of the United States.
I will bear
I will
truth and
bear true faith and allegiance.
allegiance
Constitution of the United States.
See how good you guys are in the Constitution of the State
California.
of California.
Constitution of the State of California.
That I take this obligation freely
Take this
I
obligation.
take this obligation freely
without any mental reservation or purpose of evasion.
Without any mental reservation or purpose of evasion.
I'm thinking. I'm just kidding. I take this obligation without any mental reservation
Or purpose of evasion.
or purpose of evasion.
And that I will
That I will.
And
That I will.
well and faithfully discharge
Will
Will and
faithfully
faithfully discharge
the duties upon which I am about to enter.
duties
the
upon
duties
which.
upon which I am about to enter.
Congratulations.
Thank you.
Now, before we approve the agenda, what I'd like to do is Mr. Gordon invocation and Mr. Blythe flags.
This first.
I would like to do his first.
Would you all please join me? Heavenly Father, we just ask that you be with us as we guard and guide and direct the decision-making at the hospital, so it would benefit the members of the community, and we could enrich all their lives. In Jesus' name we pray. Amen.
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 Please place your right hand over your heart and repeat after me. I pledge allegiance to the flag
The flag
of the United
of the
States of
United
America.
States of America and to the republic
Which stands one nation under God,
God,
indivisible,
visible
with
with
liberty and
liberty
justice.
and justice for all.
Is there an echo?
It was not big time lag. Okay. It's the mission statement is item C3 for all to read. I've not read it at this time. It's there for you to review. But approval of agenda. Before we move down, we have any changes that we need to make on the
Make a
agenda?
motion we approve it as presented.
I'll second.
Thank you. Okay. Catherine, your vote?
Yes.
Gene?
Yes.
John? Yep. And I'm a yes. Okay, item D, public comment. Do you have anyone from the public that wishes to be heard? Seeing none, hearing none. Okay. Item E, consent agenda. The following items are considered routine and non-controversial by hospital staff. Consent will be acted on in one single motion unless we have any changes that need to be made or presented by the board. Do you have any changes on consent?
I'd like to pull items 12 and 13. Chief Medical Staff Report and the Chief Nursing Officer Report. I just had questions on their reports.
Okay.
I don't know if Gary, Dr. Finstead's here, but maybe you can answer.
Would you like those to move to F? Make that 2 and 3?
Wherever you want, Mr.
Right.
Chairman.
Let's take number 12. We'll make that item 2. And Chief Nursing Officer will make his item 3. F on reports. There. Do you have any other changes?
Unfortunately, I didn't have a chance to read everything on consent. I talked about it with Heidi, the encrypted messaging, so
So I get to harass you?
If you wish,
I would like to do that because it's entertaining.
there's a surprise.
No problem. But, yeah, I mean, obviously, if there's anything you're uncomfortable with, you can abstain, you can object, whatever you want to do as we proceed. We have any other changes to agenda? Consent, forgive me.
Motion to approve
Motion.
consent agenda,
Thank you.
minus the two we pulled.
Minus the two. Can I have a second?
I'll second.
Thank you, Chief. Okay. Catherine, your vote?
Yes.
Mr. Blythe?
Abstain.
Mr. Parks?
Yes.
Yes.
And I'm a yes. Okay. All right, let's get through. Roll on through them to item F1. Tim?
Thank you. Couple of items, but this, I completed, we've going to name a distinct part nursing facility salary survey for this, the Department of Healthcare Services. And this is kind of was for me a unique situation because in essence, the state was asking us to go back and relook at the salaries that we pay, the rates that we're paying for our staff within the SNP and those affiliated with the SNP. And so, and the purpose of this is they're going to go back and use this to reset our rates this next year in light of the new minimum wage adjustments that were made this last year. Normally, they would just compare. And so I thought that was rather unique that they were doing. And so John and Amy worked on that and we've got that set in on time and so forth. So
Wonderful.
yeah.
What they were asking for is anybody paid under $25 per hour.
Right.
That's what we presented to them.
Yeah, and obviously we're not required to pay the minimum of 25, so yes, that actually done. We have a backflow device that went south on us, Bob said over there, that needs to be replaced. Did you want to chat about this just for a second?
Yes, so backflow devices is in case of a loss of power or loss of pressure from the water district. No contaminated water can be pulled back into the piping systems of the water district. And so one that's been in there has been in there for many, many years. It's been rebuilt many times and it's no longer rebuildable. So we are going to replace it. It does require me pulling a permit with OSHPA and HCI, which I'm in the process of doing through what's called the freer manual. It's a field review process, but we're submitting through Sacramento for field review by Bruce Bigger and approval and permit to literally undo 12 bolts, lift the old one out, set the new one in, 12 bolts, turn it back on.
What diameter unit is above?
4-inch.
4-inch.
The other thing too that we had going on significant maintenance wise, Bob, you talk about the mixing valve, as we were looking at the issues that we had over on the acute unit as it related to hot water. It's an issue with the showers that we had that we couldn't get enough hot water down there. We found an issue with that mixing valve that Bob is now trying to get replaced.
Yeah, we have what we do on the newer buildings is we heat our water to 165 degrees. The 165 degree water goes to the dishwashing machine. 140 degree loop goes to the 3-bay sink in the kitchen, and also the hotter one also goes to laundry. And then the 120 degree loop goes to all hand washing sinks and showers so that you can't scald anybody. It is a 3-way mixing valve that takes the return water, adds some cold water, adds heated water, so that it always comes out at 120, not to exceed 120, not to go below 106. And that valve went bad on us. And so we are currently regulating it with manual valves, checking it like every hour and adjusting the valves until we get it. The challenge is it's a custom order item. Manufactured to the specifications we need on the bulb sensor system and the length of the pitot tube and the and the size of the valve and the temperature ranges we needed to do. So it's 6 to 8 weeks out. And so we are manually adjusting the temperatures.
We're gonna manually adjust that every hour for 6 to 8 weeks.
Choice.
Was that the
Yeah, you
problem?
can't run your temperature
The
below that. Or
Two
you're not gonna
end
get the
units
clean-
on the loop not getting temperature to the shower.
No, that, this is not the water system that does acute care.
Okay,
That's not a separate water system.
thank you.
This does dietary surgery and SNF.
So can we get HCI approval just to do it as soon as possible?
That one, I am not. That mixing valve, I don't need to get permission from because it's literally a maintenance replacement. This valve that costs $4,000 is only this big.
Okay,
And it's just simply undoing some unions and putting the new one in.
Just getting the parts.
It falls under minor repairs that don't need a permit.
Okay.
Whereas the great big 4-inch backflow connection to the city utility does.
okay.
Yeah.
Wow.
Building's getting old.
Wow.
Well, there's another one we're working on, but he's not prepared to talk
Yeah.
about that one.
Oh, you're talking the chiller system.
Yes.
Would it be prudent to buy 2 of them and keep one in stock?
Well, I actually have 3 and all 3 need to be replaced, but right now we're replacing the main one. What it is like I said, the water's brought up to 165. We drop it, we take that directly to certain areas, then the 140 loop goes, and that mixing valve is not working well. But we're in the neighborhood of 140, and for that sink, which is really only the big 3-bay sink in the kitchen, we're okay on, but I would like to replace it. Then there's actually a bypass on the 120 loop, so that when I'm working on the main valve, we could be on the bypass. And that one hasn't functioned for years. And so, but I got to start with the one that is really, really important because, literally the water system also has a sensor on it. So if it exceeds like 130 degrees, it shuts and no water goes out to the building. So you cannot scald anybody. It's a safety. That functions.
Okay.
We tested it the other day. Accident.
Could you adjust it to where you could only, the hot water would only come through at a certain temperature? You could bring it down to,
I
Just
could
below.
lower boilers down to 120,
right,
but then I don't have hot enough water for dishwashing or clothes washing. So it's quite a complex system.
Wow.
But it's circulating lines that go through all the buildings, and I have temperature gauges on the outgoing, temperature gauges on the return, because the return can't be below 106.
This doesn't trigger our ineligibility for that FEMA grant, does it?
No.
If we spend money on this
Because this
plumbing
That
project?
repaired me.
This is minor repairs on the buildings that are not in the newer buildings.
Okay,
Thank you.
so we're not, so these needs you just described of these 3 valves, it's not part of the building project?
This is just maintenance.
main,
Well, shouldn't we move forward to have those other valves replaced too, since we know? So we don't end up having to
Check them.
check manually in the future?
I'm enjoying it.
Yeah, I can't imagine that.
Let's bring it up in building. plan.
We can do that, yeah. Good idea. We get a bid for it.
All right.
Thank you. Pleasure.
Okay, thank you. We are, started, executive team, we started to work on a parity adjustment plan for the employees. This would primarily impact the employees who were not adjusted as part of the minimum wage changes that we put in place earlier this year. And so forth. We've done like 2 years in a row where we've gone back and done the lower levels because that was mandated to do. And so, but now we're seeing the compression that's beginning to hit us as we move them up against the higher, middle to the higher level. So we're going back and modifying those now as well and creating new ranges for each high and low ranges for each position within the hospital. So that work has started. Hope to have that done in January, obviously, so that we can get that back here to the board approved for distribution to the patients or to the employees, excuse me. we're invited to a crisis response training meeting that was being held over at Pinecone Inn. Was being put on by the Kern County Fire Department as well as a group out of Washington. And so this is to prepare, it focuses on individual and group crisis planning and the response to that. And it provides training for those critical incident for stress response as well as mental health crisis, which is certainly something that we run across frequently here in the hospital. Our plan is to send about 5 or 6 people to that. There was a cost of that for about $135 to $150 per person. It's a 3-day training course. And so I follow up with Heather Berry this morning on that. And apparently she had sent me an email the other day saying, hold off on the registrations. And so I was a little concerned that maybe they'd met their threshold or something like that. But it turns out that apparently Washington got back to them and told them you can't charge for this. So, so it's free. So
That's nice.
so anyway, she's getting everything redone and then she's going to send me the invitation.
Good. Let's send 10.
We can.
We still have to pay this.
Yeah. So, but the point is, yeah, we'd save some money on that stuff. So, but yeah, this is being done by a group that does this all over the country. They're noted for it and they got great response. Kern Fire is helping underwrite some other of the costs and stuff like that. So yeah, we've got a number of people. The issue, like I said, for us is just trying to, who can we give up for 3 days to go out to this training and stuff like that. So it makes it a little hard, especially with nursing.
Is that the meeting where they teach you how to do the Trump dance?
I haven't heard of it.
We've already got that one down.
Just, we received good news. The state had, obviously the voters this year had approved the MCO tax resolution that went through. This is one that would provide 100% of the MCO. The MCO tax is a managed care organization tax. And the health plans are charged a fee, this tax that goes into them. They receive funding from Medicare from the state federal government that matches this stuff, and then it comes back out to the health plans. And this is the source of our IGT funds and so forth. So what the state had been doing is basically planning to pull off about a little over $1 billion of that to use for the state general fund. And they tried negotiating with the governor in response to some things for seismic and some of these other things, which he ultimately vetoed this last year, as we knew. And so anyway, the state went ahead, the hospital association, with the getting this ballot initiative approved, ballot measure 35. And apparently is now putting all of that money back in. And this is one of the things that's leading to a big increase in reimbursement that we have. A lot of it's coming in for providers. That's the TRI thing, which was 87.5% of Medicare rates versus 115% that we're getting now of Medi-Cal rates. So going to be a big increase for us with regards to payment for physician care and stuff like that, which will ultimately end up back with us since we built for majority of that stuff. So that's good. And then also, like this, you and I were talking earlier, there's some other monies that have come through that were not expected, which were pretty significant dollar amounts through them. So hopefully we will see some other monies made available through that or through additional grant funding opportunities.
It's likely to come through in quality performance measures.
Yeah, I know they're trying to put more emphasis on that to try and get better results on
Yeah,
that.
so we'll need to jump on that bandwagon if we want some of that money.
Absolutely. Yep. So, one of the issues we've had recently is we've been having difficulty in getting more of our controlled medications approved through Cardinal. And so if we're going to put the orders in, they'll just say, no, we're not going to fill that anymore. You reached your max. And so forth. And, we had applied a couple of times with Cardinal to get our volume orders increased, primarily because of the influx of new patients that we had that came over when the pharmacy closed and so forth. And they made an initial increase in our allotment of those meds. And so that worked for a while, but that's continuing now to change. And one of the things we're noting when we followed up with Cardinal was the fact that they were seeing an increase in the actual number of prescriptions per patient and so forth. And so much higher utilization. And so, and it was interesting because Suter received a phone call today from, I guess, the former owner of the pharmacy over there, indicating that was apparently one of the reasons why he was kind of getting out of the business, was because they were having difficulty managing the controlled substances that were being ordered, and so forth. So she's gone through and put some reports together by provider for us so we can take a look at the ordering practices.
You're talking about the one in Kernville. That's why you went out of business.
That's what he said. He apparently gave up that today. That information.
We should be able to justify if we're given more, maybe sicker people are sicker, but we've got more people.
That's one of the things.
On hospice or
Yeah,
something.
that's one of the things we're having to go back and look at it. You know, we got some breakdowns from them as it relates to each provider. So we have it by provider. I think we've got it back going for like 10 months or something like that.
Yeah, that
So-
shouldn't be an issue. That should be.
Yeah,
We're
well,
not gonna give it out where it's not needed.
well, like I said, what we're finding out is some of these patients apparently were getting high doses of this stuff get handed out. And so one of the things now, we're now being confronted with it because like I said, now their orders are catching up with them. And so forth. And we're gonna go back and we've got to have individual meetings with the physicians now to go back and relook at their patterns, at least in terms of the data that we've received. And so we've got it for a period before and we've got it for a period after to see how that's changed.
With physicians have an affiliation with the district,
Some do, yeah. Some are from over there.
we have to police them.
Yeah, well, because they're they're writing the orders and we're trying to fill those.
Right.
Well, they're coming through and we're not gonna have enough for our patients and so forth if that's the case. So if there's a bunch of them that are coming from across the lake and so forth from those prescriptions that are much higher utilization on a patient basis.
I see.
So it's a heavier concentration of control. So now we're going back and relooking at those and trying to figure out what can we do to get that back under control so that it doesn't create an impact for us of freezing us out for others, because then everybody suffers as a result of that. So, yeah, there's some issues all over. And so we're going back and we're taking a look at that. We're asking for additional information every time they place an order. Like what's the diagnosis of the patient when you're ordering these medications and those kinds of things. At least if we have that, then they will cut us some slack and potentially give us more. So
Well, this goes way back. 25 years ago, the government added pain to the vital signs
Yeah.
initiative. So anybody who complained of pain more than 3 or 4 on a scale of 1 to 10 got narcotics. The government decided that, oh, we messed up because now we got all these people addicted to narcotics. Now they're changing their tune and they're actually controlling much more how many narcotics anybody can get at one time. So they've changed their practices. They put all these stop measures and these restrictions on it. So that's what we're having to deal with.
yeah, this came up a couple of years ago because they literally would only send us half of our order. Then we placed that. I know we brought that up.
Is there any possibility, because Mark did that program a few years ago, the opioid outreach?
Yeah.
Is there any possibility, I thought that was a really good program that you did.
Yeah.
Is there any chance of exploring that down the road from an education?
I would like to see us do something like that, primarily because I know the Hospital Association and other organizations are still honoring those hospitals that have these opioid programs in place.
The CSI momentum, there's
Yeah.
still grant money out there for that. We just,
Yeah.
We went out and got, a lot of talent to come out and talk to the kids at the schools about drugs and narcotics and things.
It's causing a lot of people to kill themselves. So they're getting that stuff out of Mexico and China.
Oh, that's true.
For-
That's true. So anyway, yeah, we're trying to get our hands around that and see what we can do, but certainly identify, even just because again, a lot of times I don't know that these providers actually know how much they're ordering. In the course of a day, you're going one patient after another and stuff like this. You write your prescriptions and so forth, but so yeah, we've got some work to do there. Quick update on the Anthem situation. We've been in daily contact with them. They have identified at least 5 patients who had received letters Sherry has helped me greatly in terms of putting together a list of other patients, at least 8 other patients that we've identified, which I forwarded back to them to verify with us. They, again, it appears that most of these cases that we've had that were affiliated with Dignity. BFMC, apparently we're not having a problem with those. I thought there was one initially when we first came through, but apparently they've got their act together and everything's coming through cleanly on that. We're not seeing any changes there. Couple other things, like I said, with Dignity, just received a letter this morning, was a contract adjustment for Dignity with Anthem for Blue Shield of California Medicare. They notified us that effective January 1, they are terminating the contract with Dignity, as well as Cigna Healthcare of California. That's a commercial plan. That one actually canceled back in April 15th. I'd asked Sherry to go and check to see how many patients were involved, and I think it was like 6.
Had zero Cigna patients.
Yeah.
And out of Blue Shield managed, Medicare managed plans, we had 5.
Yeah.
And out of that 5, only 1 is assigned to us.
Yeah, because I wanted to know how many we had, because if we needed to reach out to them to see if we can't get them into another plan that we've got, I want to make sure we'll be able to hold on to those folks. So anyway, doesn't appear to be a huge problem. But again, just a lot of things. I know Andy was questioning what's going on with Dignity. Apparently they're getting a lot of contract plans, or plans that are canceling them lately. Just a lot of things going on. So, but we're reaching out to the patients and, just trying to stay on top of that and make sure that they can continue to see their patients here and so forth. So.
You know what's causing Dignity to have a problem?
What's the?
No, I'm asking.
Oh, I don't know. No.
Because they had a pretty good system of getting their doctors and nurses and everything, so they're growing them.
The, one of the issues, they have historically had a contentious relationship with Anthem. I know a year ago, they canceled all their contracts with Anthem, primarily because of rate issues and so forth. And finally, the Anthem caved a little bit and gave them a bigger increase than they had originally presented. And they've taken a much more aggressive role. And so when I reached out to Andy to try to find out why were these terminated, I said, was this Dignity terminating these plans, or was it the plans terminating Dignity? And it turns out they were both terminating Dignity. And the Cigna plan was actually because of a lack of membership. There just wasn't enough people in Kern County to make it worthwhile. And so that's why they canceled that one. The Blue Shield contract, basically, and this came from a Dignity person who admitted that apparently they were being terminated for various reasons. And that's as far as I could get in terms of what was going on.
It's easier for us to deal with them, from what I see, because we don't have a lot of volume either, so it don't affect them either way.
Yeah.
It's best just to give us a decent deal and go on with life.
And that's what we tried to do. That's where Andy really helps us, because
And
he puts
it's
all
very
together. And it's been very good. As a matter of fact, John and I have a meeting coming up with him shortly to go through all of the rest of our contracts. We primarily give him the big ones to work on and so forth, but as we found out, we've got a bunch of other ones there that I don't think he's ever seen. So we're going to get him working on those. We had another letter. We had a letter from a patient that came just the other day, who apparently has been a long-term patient in our clinic.
Yeah, so they were originally with Blue Care Cross First Care, but effective January 1st, they will be with Blue Shield Helpers. So they received a letter stating, even though it's a PPO plan, they wanted to assign a provider of PCP. And the letter states that Blue Shield selected Dr. Gross as that provider. So the wife got online, the only 2 providers that she can find in her area, 15 miles from her address, is Dr. Gross and Dr. Finstead. Dr. Mongar wasn't listed, so she had called, and Blue Shield said it's because Mongar is not a contracted provider with them.
So I've reached out to Andy. Andy is working on getting us a CalPERS
That
contract.
works out like BFMC.
Yeah.
They've got a unique contract with them. And so they probably don't have the other end of the other.
Yeah, like I said, these are the only
It's probably a
providers.
BFC problem.
So Anyway, Andy's gonna reach out. He's got contacted Blue Shield, see if he can get us onto that CalPERS. He said he just about a month or so ago negotiated one for Mammoth Hospital and another one. So he said it shouldn't be an issue for him. It's just gonna go and tag it on the back of that one, and so forth. And then we'll get the Dr. Monger and the others credentialed for them as well. So we'll get them on. So again, I don't think there's a lot of life right now in that, but we want to make sure that we've got access for the
Yeah,
patients.
so they can see, I mean, it is a few care plans, so they can see any provider that they want, but if they're not seeing a provider that's in their network, then it's gonna be more out-of-pocket expense for the patient.
15% more they can charge.
I reached out to the VA, finally got a hold of Leandro Chara. Been trying for a number of months to get a hold of him, and he just hasn't been available. He shared with me yesterday morning that apparently he was out with significant medical issue. And as a result, he is no longer in that position as the chief experience officer. So he is no longer doing the deal. And so, and nobody has been appointed for that position yet. What he did share with me is the name and phone number and address of Alan Trin, who is the person who is apparently working on getting Lancaster's new VA clinic open, and so forth. So he said, reach out to him. He's kind of temporarily foreseeing things and stuff like that, but they don't know what's going on there. Yeah, he apologized that he hadn't been around.
So I did have a conversation with Congressman Fong's, one of his representatives, Samantha Mitchell.
Mhm.
So she does all our veterans outreach for Congressman Fong.
Right.
And I talked to her, she said that the VA is having some budget issues, but there are grants available. She says if we can somehow figure out a way to get the healthcare district to still do the arrangement, but use some grant funding and keep it here in the valley rather than give it to the VA, which will go all over the country. That way it'd be at least kept here in the valley and within the district.
Okay, I'd be happy to reach out to her to talk about that.
I'll give you her number. I have her number.
Perfect, great. Yeah, because like I said, one of the things, a couple opportunities, obviously, one is doing something here if there's a way to take some of that money and either modify our clinics here to be able to take on for some of that. The other option is the property, potentially Bodfish, that we could use as a potential site.
Yeah.
That was keeping what they want to do. So, and I chatted with him about that recently. So, yeah, that's great. I'll reach out to them. Then just had a meeting, Cassandra and I had a meeting yesterday with Beta. We did a pretty thorough review of all of our open workers' comp claims. Just trying to understand where we're at, how do we get more of these things closed? With several of them, I think, that are within the next month or so, they're hoping they can get off the books and so forth. So nothing that was out there that was way out of line or huge dollar issues and stuff like that. So I felt pretty good about it. So anyway, that's it.
Questions for Tim?
I just had a quick side question. I don't know, maybe it's too premature. Maybe it has nothing to do with anything, but, a couple of weeks ago, there was that CEO of United Healthcare that got assassinated in New York. That's kind of rattled the health insurance part of the industry. Any input on that or how that might affect insurance plans going forward with, patients being upset or anything like that?
I think, yeah, we've actually had a lot of contact. We had a CEO meeting last night. A lot of concern obviously raised over that. Not so much, I think, from the hospital CEOs at this point, but the health plans. Because one of the things that was identified was that a number of these health plans are using these algorithms for denials. One was actually using an AI model that was automatically denying like 50% of the claims and so forth, and then expecting the patients to come back and argue their point, and then maybe they might get someone real to talk to. One of the other ones we just heard the other day, I think it was, matter of fact, I think it was Anthem, was 1 in 10
1 in 10
are just being denied.
Yeah, a husband and wife going same service. One got denied, one got paid, just because it was The
the
10th
cycle,
one.
yeah.
Oh, really? Oh, my God.
So, yeah, so that's what's creating a lot of problem. And I think what we're hearing through the hospital association and other, because they're kind of keeping an eye on that, is that there's probably going to be quite a bit of effort to go back and relook at their models of how they're doing that. I think that as terrible as it was,
I
yeah,
hope so.
it was, it opened a lot of people's eyes to what was going on with the insurance companies and so forth. 'Cause you figure these people are paying their fees, to participate in these plans and get care. And then they turn around and deny, for no.
Why aren't they being criminally pursued?
I think
for
they should.
killing?
Come to that.
I think they should.
Well,
United Healthcare actually denied twice as many as the industry average.
yeah.
That's what I.
And the guy was kind of bragging about it almost, that not the guy that got killed, but his higher up was actually talking about it.
From 10 to 20%, they doubled the amount that were denied.
Right.
And like Tim says, they're using AI to do it. That's one of these companies can start doing it, but
Maybe there'll be a push to just get rid of private insurance for medical coverage and have it be a government function. Like
You should
the
have
rest of the world.
no medical for anybody. If you get sick, you die.
Call it. Always option B.
Yeah, so anyway, I wouldn't say expect changes. I think what's gonna happen, so.
Thank you.
You're welcome.
Pete, any questions for Tim?
No.
Catherine?
No questions. Thank you.
Questions or criticisms?
Yeah.
Thank you later.
All right, moving on to the med staff.
Okay. We got a written report from our medical director and
Page 30.
page 33 there. There was something on there that made me go, huh. It's under the bioethics committee. Discuss dilemmas of rural hospitals and staff frustration and burnout. Does that relate to the critical incident stress training that is coming up? Is that, I'm not sure what this is in reference.
So
to.
that's in reference to the burnout that's come post-COVID.
Okay,
And Irina's been doing classes nonstop about staff frustration and burnout. So
Irene is somebody internal?
Social service.
internal,
Okay.
she's works for us. Yeah, and she's social work. And she,
So we're making an effort.
we are definitely making
Oh,
an
yeah.
effort
Okay.
to kind of address some of the staff frustration
Okay,
that we see. Staffing is always, again, you guys remember in a span of 2 months, I lost 8 nurses. It was pretty devastating. And we have a tendency to internalize some of it, but still just keep covering shifts. I mean, that's just the way we do it. And it does create some.
you can
burden.
only do that for so long.
That's
too.
right. And we're getting some of that replaced now. Some of the folks are coming back from their maternity leave.
Okay.
But I got another one going out on maternity leave in February. So it's just kind of like, it's a revolving
cycle.
door sometimes, but we are addressing those concerns.
Okay.
Yes, sir.
All right. Do we need to make a bigger effort to do it?
Well, that's one of the reasons why I think we have this go on here for a while. It's just, again, something, it's gonna be like a standing item for us there.
Okay,
It
Just
is.
they're gonna keep watching this and kind of what we're hearing from staff.
I'm glad it's being discussed.
Yeah.
If you need to bring it to the board level, please do.
Yeah.
Like, I think this is really important and we need to take care of our folks.
Absolutely.
Now, the next item, the next sentence there under the bioethics committee, the issues of vaccine administration without ability to consent. Or that-
Yeah,
what does that
let me
mean?
explain that one too. What happened there was, again, there was efforts obviously during COVID to get every single one of your residents vaccinated. And then obviously we've got others that we need them to do flu shots, pneumonia, those, and so forth. So for the most part, we did a pretty good job during COVID. We got all of them vaccinated and so forth, primarily because they could all consent. The issue now is we have several patients over there who are lucid. They can make their own decisions, but they choose not to do so, even though medically they believe that they really needed and so forth. And so this was more like one of these topics we talk about, these dilemmas that we get into. How do you do this when you have patients who, and the other issue that went along with this, the family wanted it done, but the patient did not. And so that was a question, this is because they thought it was better for them and so forth. But as long as that person is capable of making their own decisions, you can't do anything and so forth.
It's assault if you try to do it without.
Correct.
Right.
And so this is what we've kind of talked about. And we're seeing more and more of this now as we've kind of come out of this whole COVID area. We're beginning to see the vaccination rates drop across the board and so forth. And I think that's got some people concerned. And so, we're trying to talk about this kind of in advance of just trying to understand what can we do? What are the limits of our ability when we have these kinds of situations where we know patients can certainly, it would be better for them. But, if they don't want, like I said, it's the frustration that we have.
Can we call Fauci?
Speaking of frustration, right? Yeah, so he's the last person we want to call. But anyway, yeah, so that's kind of what we're going on.
Okay.
So what we try to do in that committee is really take a look at some of the key issues that are going on nationally or statewide, or here locally, community. And we just chat about those and just try to, refresh ourselves in the event that something comes up. How will we deal with it? Instead of trying to scramble at that moment in time, trying to decide, sure, this is the actions we want to take. We've talked it out, we've worked through scenarios and so forth. Mark typically bring scenarios that we've had either in ER or in acute or elsewhere that we talk about to, so if it comes up again, we have a strategy to how to deal with it quickly. So,
Okay.
So that happens frequently.
Rural hospital dilemma.
Is this something you can handle with when you're accepting a patient to the facility as part of they're going to agree to this if they want to live there?
Conditional medicine, I don't know that you can.
Well, they do it
They're
with-
coming in for one reason and, go ahead, you were gonna say
No,
something.
they do it with public schools. You've got to get certain vaccines to attend this public school. Like, that's the model.
I'm sure this part of it's a funding issue. You want to do this, want the money, you're gonna have to do what we tell you to do. I don't know. I don't have an answer for that.
Yeah.
It's, the point is patients have free will, as long as they're.
Those vaccines are a lot more proven than what you're talking about than Fauci's ingredients.
Yeah, I'm just,
Polio. and-
Fauci's ingredient.
I'm just thinking that the ethical,
Fauci cocktail.
the ethical issue, is, it could be, I don't know what's being discussed, but it could be you need this vaccination to protect everybody around you.
As part of the discussion. Yes, exactly.
And so whether you want it or not, if you're going to live here, you need to accept it for the
Well,
greater
we had,
good.
we approached the smoke dilemma with the same vigor and found out we were losing admissions because we told them they couldn't smoke at the facility.
Interesting.
So we opened up a smoking area where that's where they smoke now.
Okay.
And so we can accept patients who smoke, but people are just saying, no, I just won't come there. I mean, it truly is.
Okay.
They have free will to.
Yeah.
And we can tell them, so if you get sick, then it's your fault. So.
Right.
The vaccine's still not proven like.
And we
Oh,
can
no,
quarantine
yeah.
them. Right.
Yeah.
We can quarantine them if they get sick.
Sure.
Right.
Sure.
They're not,
Which we
yeah, to their room.
Well, anyway, thank you. Thank you for the
You
discussion.
would love to be a part of that. We're always looking for more people to come in and give their thoughts.
I'd
Yeah,
love
the
to
only
sit in
quarterly
on one.
meeting you could.
Yeah, I'd love
Yeah.
to sit in on.
Okay, we'll let you know the next time we have. one.
Okay. Right at my house.
Yeah.
Okay, and the chief nursing officer report. Mark, you had mentioned something about measuring productivity.
Yes, sir.
How do you do that?
Well, that's it's in discussion. So we're trying to come up with ways to do that. We don't have there's no matrix or model. We just have to look at what topics were discussed and what solutions we had come up with. Like Carrie, for instance, has a process improvement committee that we have weekly on Tuesdays. And we've we've probably saved, I don't know how many. So here's an example of what we came up with in process improvement. Lindsay's department in PT is almost paperless. So we've been able to develop and put tracking measures in place and basically do away with all the paper in that department. And so these are kind of the productivity things that we want to look at. And, you know, it's just just being more efficient, trying to come up with ways to measure it and then and so we have in the formatting, we have the subject that we bring up, like getting rid of paper. And then we talk about the discussion, who's going to do what next week and bring that next week to the table. And then once we complete a project, we put it into the completed task folder and we go, you know, go on to the next. It's a really a good way to stay on top of stuff and just, I think it's a great tool, a good efficient practice.
It does allow us to go back to later on.
As far as
how much
that's right.
Yeah.
And as far as measuring productivity, it's on individuals to get their stuff done. So now, like if I have a project, I can go into that folder myself. It's a shared folder. And I can say, this is what I've done. And we all look at it next week on Tuesday. All right, Mark was able to look at the barcode medication administration trending in the ER for that new project where we put BCMA in there. So these are all, it's a to measure productivity. I'm not sure that's the right term, but at least monitor what we're doing.
We had one issue that came up obviously with regards to, because we were kind of receiving mixed messages as to, you know, translation of forms. You know, most of our stuff is translated in English and in Spanish, or some of our stuff is in Spanish. They come out with that there were 15 languages that are accepted here in the US for use in public facilities and so forth. And so we got Scott involved in that as well, because we're sitting there going, Jesus, how much is it going to cost for us to go back and translate these forms if we've got someone who's coming in who's, you know, German or, you know, whatever, or, you know, and so we went back through.
Or Serbo-Croatian.
Yeah.
That's not one.
Punjabi is. But so anyway, like I said, yeah, Scott was able to go back and we take a look at the makeup of our community here in terms of the languages that are spoken here. And we were able to find out, I mean, English, obviously vast majority of patients live here or speak English. And there was a small portion, I think, that spoke Spanish. And then like 1% that spoke some other language and stuff like that. And so based on that, your threshold was 1,000 lives within that community or 5% and so forth, which would be for our population here would be about 900 people that specifically spoke that language. And so based on that, we were able to limit it to just the Spanish and English and so forth. So that, you know, we were looking at some big dollars to go back and translate these things.
But we got translation available if it's an individual, right?
We do, yes. Language.
So that, I mean,
Yeah, and that's what some of the hospitals did. I mean, we checked with some of the other hospitals. I think Sherry was involved with that, and reached out to Mammoth or Northern.
we just don't have to print everything.
Correct. That's exactly right.
We found a company to do it for $140 a document.
Hmm.
It's gonna be a lot smaller than we thought.
Yeah.
It was gonna be
14 times there.
Yeah, now we're only doing two, so $280.
Yeah.
So the other question I
The
had,
other, I'm sorry, I was the one thing I was gonna add, as it related to that forms issue, and the, one of the things we really began taking a look at, because we have so many meetings going on, and so forth, and it's not uncommon to find him, Mark, John, me, and others. I mean, we got a lot of high-priced people sitting around the table, you know, for one meeting right after an next and stuff like this, and we're going, do we have to have all of those people here? You know, if this is predominantly a nursing issue, then Mark should be the administrative or representative at that meeting. Unless they're specific that maybe we need something from John or something IT related or whatever. So we're trying to go back and take a look at the membership of some of those committees and pare down. One, because it gives us more free time to get stuff done. Because again, Tuesdays for us are usually horrible. Usually got back-to-back meetings all day. So that's what we're trying. So one of the other things that we kind of talked about with that.
We're also trying to make the meetings more efficient by maybe limiting time on each topic.
Yeah. Those are-
We actually have stand-up meetings. We don't sit down and.
Those are really effective. They can be.
The short break cookies.
These right. Yeah, everybody. The next thing I'm gonna do.
So, yeah, now we're looking at all kinds of things just to kind of be more efficient.
Who's Dr. Stemmer?
Dr. Stemmer is a surgeon from Ridgecrest,
Okay.
and he has applied for credentialing here. And we're courting the idea because he does GI
He's a
and he
surgeon?
does surgery.
Okay.
He's a general surgeon. Now, the trouble with this is we still are limited as to what we can do here. We don't have an ICU, so he can't do these big open procedures, but some same-day surgery stuff. He can. So that's what we're working
All
on.
that you say you could do.
Okay.
So right now, we're really waiting on him. He's got to get his privileges. He's got to get some clearances some things that were going on with him.
And Travis is retired, so we no longer have a CRNA.
Oh.
So we do have to get a CRNA.
So some of the time frame in terms of making these things happen, because you say, great, let's do this, let's get it done. But the issue is one thing that's got to happen here. And like I said, if he doesn't get that, then I'm not going out and bringing on or hiring this CRNA.
Sure.
And all these other nurses and getting my equipment fixed back there.
We get a whole team here and then he doesn't show.
Yeah, then, right, we're,
Money down the tubes.
right. So we're trying to
Baby steps.
be efficient
Okay.
in how we do that.
All right.
Not overspend.
Thank you.
Absolutely.
So if he gets credentials here, is there any possibility that some of his volume or clients in Ridgecrest could potentially come over here and utilize our hospital? Or
Probably all of it.
Okay,
He was their number one surgeon at Ridgecrest
that's what I thought.
and he left. Yeah. And he got,
Let's just say he left.
yeah, he just, yeah, he left. It was his decision to go elsewhere.
Did he have to cut his way out?
He's one of those guys who, yeah, so he's,
Thank you, Brett. That was all I had. Yeah.
I think those two things have got to be.
Okay, so now we need to.
Oh, that's right. Thank you, John. I'll make it.
And since I read it during the meeting, I'm comfortable.
That's right.
he's a parliamentarian.
Taking the motion.
You need a motion.
Ross makes the motion.
I'll make the motion. Did John make it?
No.
Oh, you did, so I just got you off.
Okay.
Gene, your vote?
Yes.
Catherine?
Yes,
Yes. What? Mr.
Yeah.
I'm a yes. Thank you, sir.
Thanks, John.
All right.
We did offer the CNA instructor we made her an offer. So we will have that CRNA or the
No.
CNA instructor
Good job.
in spring.
Good job. Great.
All right, moving on to G, old business contract review for the current systems.
Yes.
Who wants to handle that?
You want me to handle? Yeah.
I didn't see any documents on that.
I think it was just a discussion. It was just a discussion. Gene wanted us
It just
to,
shows as an action item. That's why I was asking.
yeah, because we wanted this, Gene was curious of how we were using that product in the hospital because it's a $500 and we're going to continue. So
Okay.
I had Deb some analysis for what we use it for. And I'm just kind of going to read what she says. We're going to use it for a minimum of 4 videos per month. 2 of those videos would be a continuation of Tuesday with Tiffany, and we're going to add 1 more for physical therapy. The additional 2 videos would be provided by Serrano, tailored specifically for our demographics. And then we came up with a list, or she came up with a list of the next 6 months or so of the videos that we're going to use. Glaucoma awareness, our healthy gallbladder, in February and March, National Nutrition Month, in April, Foot Health Awareness Month in May, Skin Cancer Awareness Month, and in June, Men's Health, specifically for all brain awareness.
On that one.
And so these are pre-canned videos that we don't have to do any vetting to make sure that it's medically sound. That's all taken care of for us. So on top of that, just those videos, they estimate a minimum of 24 hours a month if we were doing this, 24 hours a month to gather information for the topics that we have. 16 hours a month to videotape and upload and create the video for PT and dietary. We'd also have to purchase additional software to make it on our own. And so with all of that together, it's about 40 hours per month at $35 per hour times 40. We're looking at $1,400 per month if we were to just take what they're doing and do it ourselves.
As long as.
Well, there's a kicker to
Because
this
there's a
too.
need for it. If we just are doing it and creating other activities for nothing, if it's not a benefit, sometimes pure, simple and sweet is better. So.
I don't disagree.
You guys are the ones doing it. And if you feel like it's good, I'm good with it, but.
Yeah.
Well, in full transparency, this last week, it's funny that this got brought up last month, but this week or last week, they came to us and said that we're raising your prices 80%. So it's going from $500 per month to $900 per month. So we are certainly considering this as something that we're going to get rid of. I reached out to them and basically said, that's crazy. That's an 80% increase.
There are other people that you can buy from?
We're looking into that too.
Okay,
Yeah.
okay. I didn't want to create a problem when I asked
You
about
didn't
it.
create any problem.
Okay, okay.
Yeah.
So whatever you do, I'm fine with it. Yeah, I'm sure you'll bring it back to the board, so.
Well, we can if you want to. It's not under the price where it would be needed to.
No,
If
I'm
we do something else with the
comfortable with,
provider, we'll have to bring it back to you.
Yeah.
Otherwise. if we-
yeah, I don't have a problem anymore. They got
Okay.
control. They're looking into it. That's what I
Yeah.
want.
Okay. Any other questions on?
No.
Okay.
It is an action item, so we need to move on.
It was just
How did that
information.
come up?
He gave the information.
It's a contract renewal.
I think it was on the contract renewal and Gene
Okay,
found the
then.
name and the price and asked a question about it.
But
Then can I make
the other letter.
Since then, we just got the other letter that says it's going up 80%. We have yet to decide what we're gonna do.
Okay, all right.
Can I make a motion that you can renew it as needed?
Sure,
Okay.
fine with me. You guys.
Would
decide
that work?
Works for me.
Okay.
Second thought on that.
I'll second that.
All right.
But the basic, we're
Just continue.
We're just allowing.
delegating the
Continue what
authority,
you're
Right, right,
yeah,
And
to
allowing them to make the decision as
Right.
they be.
whether it's worthwhile or not.
Yeah.
right.
That's my,
So if the price goes up, we can always cancel and go to a different service.
Or not
Yeah,
renew at all.
allow them to make
So
that.
Yeah.
whatever he wants to do.
Okay. Catherine, your vote?
I'm a yes on that.
Mr. Parks?
Yes.
Mr. White?
yes.
I'm a yes. All right. Thank you. Okay. New business. Tim, this will be for you.
Sure.
Emergency Department physician.
Yeah, we had a request from the ER physicians, Dr. Hall, their medical director, and so forth, because we have a number of times where, depending on volumes of cases that are going on that day, that we have significant issues with regards to getting documentation done on time and those kinds of things. So what they had requested is a 1 hour overlap. And I think when I brought this to Finance Committee, it was 1 hour per shift, each shift. He's come back after meeting with the guys and taking a look at the volumes and stuff like that. And so what they'd like to see, that 1 hour overlap on the night shift. And then probably only about half of the day shift. So it was a little bit less than we thought it was going to be before.
So 12 and a half for the day and 13 for the night.
No, only half of the day shifts we were where it would be approved for,
Okay,
but it'd still be 1 hour.
so they'll tailor it to the needs.
Correct. And so, in which Dr. Hall will monitor that and so forth, and I'll work with him on that as well. So they're going to keep that cost down. But apparently it's something that the nurses have expressed very positive effects from that. We did it for the 1 month and stuff like this.
The continuity of care really improves.
Yeah.
When you got one doctor going home and the other one's on and he knows nothing about what.
Yeah, I'm trying to get out the door and you're trying to come on and go, what have I got here sitting there and so forth.
Can I make a motion that we accept your
That would be great.
request?
I have a question before you talk.
Please.
So what do you estimate the cost is going to be for that
80,000 about.
a year?
Yeah.
Okay,
We were looking at 160, but we cut it in half because it only needs half
Well, no, it's actually be 120. Because it would be half of the day shift
Oh, half the day.
and all of the night shift.
Okay, 120,
Initially, it was 2 shifts per day.
Right.
It would be 160.
160.
So we cut that in half and we're trying to whittle that down a little bit more. We've had some issues.
So we're still at 10,000 a month, basically.
Yeah, it may pay for itself, though. If the documentation's better, we get paid more, it may pay for itself.
Okay.
Right.
Hopefully that's what we're hoping.
Okay.
And then we've got some other issues.
Hopefully we have a way to monitor that. So
What?
hopefully we have a way to monitor that,
We will.
track it
Well,
somehow.
Yeah, we can.
Okay, thank you. That was my question.
I'll second.
Josh?
Yeah.
Okay. Shelley, your vote?
Yes.
Yes, Catherine, your vote?
Yes.
Mr. Parks?
Yes.
Yes. And I'm a yes. Okay, thank you. All right, John, this one's for you, sir.
All right.
13 months trending.
Page 56, I think it's the last page of the packet here. This is something you all requested. I know it's kind of small writing. We could probably put it on 2 pages if you wanted, but I think kind of defeats the purpose a little bit and I'm going to follow the trends. If you can read it, that's fine. This is going to be 13 months really when I'm just taking the stats from the different board meetings and put it all together so we can kind of look at the trends a little more easily. I think it's a pretty nice report. And if you have any questions on some of the trends, we can do that every board meeting too.
Yeah, what we want to do is try to, again, there's a report in the finance package that basically shows like a 12-month trending and so forth on the financials.
Right.
Didn't have that on the stats. And so I think it's really helpful. I know because I look at it all the time in terms of how we're trending on certain things throughout the year and so forth. So I think having that where we can bring that to finance as well and just have that available for everybody, which kind of gives you a good idea. You know, I've tracked our census and our visits to the rural health clinic for almost 10 years here. I just gave up on it a couple of years ago because it was an amazing cyclic thing and it stayed right within that band. At certain times of the year it would climb up and down. In the wintertime, the summertime, it would drop off and then 1 month, boom, every time that month it would pop back up again. So it's helpful sometimes to understand the trends.
And if you want to look at something, we can always drill down on the number also and get you what makes it.
Full breakdown.
Yeah, exactly. By department or if you want really.
So the thing that caught my eye, I like this format. I'm already finding it useful.
Okay.
Is the mobile van clinic visits. We have 0 through the entire summer. Is that because school's closed? Why are we using that van?
Primarily being used with the school district.
Okay.
That's probably why. But the issue is I don't have enough people to go out and staff that thing because we'd love to be able to use it more in the community and so forth.
Can't we schedule the time?
That's good. That's what we want.
We
I mean-
can, but then I'm taking somebody out of the clinic.
Right.
That's the problem.
But it doesn't balance out financially?
Right now, they're short staffed.
Yeah.
For MAs.
Right. So it's just not the provider, but it's the supporting staff to go with it
Okay.
and so forth. So it's something Greg and I have discussed about how we can make that thing more profitable for us. So
Are we providing the services to South Fork district that we're providing to the Kernville district? You
I
know,
don't know.
Not right now.
That's right there.
oh, hi, Greg.
We are not going to South Fork now. There was very little utilization for it. And we've had decreased utilization at Wallace too. So actually, I just yesterday put it on the list to talk about it at next exec team. So
So I
Come
think
up
we
with
need
some-
to talk to South Fork. I've met them at lunch today. Somebody said, hey, he's on the board. And they kind of wonder what happened to it. They said, well, we have a contract with the district. They're supposed to be providing that service and it's not there. So I'm not sure what's going on, but I thought I'd get it on your guys' radar screen.
Is there actually a contract?
we have an MOU with them. It actually expired a couple years ago. So we had a problem with participation with the staff and getting the kids ready. So
because we were having such small volumes that we found that it was better to go to the school or to bring the kids to the office themselves. And we're kind of finding that trend with with Wallace as well, that a lot of parents would just rather get their kids seen in the office and have them focus on school as being for school. So yeah, I have a lot of ideas that I want to maybe bring up at exec team.
Okay.
Yeah, which I think it's probably a good idea to relook at that, because I know in my conversation with Emily the other day, from Kern Health, she was sharing with me that apparently a couple of the school districts are now looking to create their own internal clinics.
Their own telemedicine.
Right,
Yeah,
right,
that's what South Fork's doing.
right.
They've got a new superintendent out there. So they got a whole new management team, and they're on fire. So it might be worth talking to the guy, and but you know, if his trend is to do his own telemedicine, maybe there isn't a need for the van.
Right.
But they were still asking about it. So
Sure.
I think we need to renew the conversation because they've got new people out there.
Well, I know we also talked about if this VA arrangement moves forward, maybe seeing if the mobile clinic can go to like the DFW once a month,
Yep.
just to also utilize it. They were very impressed. They thought this is one of the best mobile clinics they've ever seen.
Really, that's great.
And so, I mean, I understand the staffing aspect of it, but I like to see it more utilized if we
Yeah.
can.
We spent $500,000 on it, sitting there doing nothing the entire summer. Well, we're shooting ourselves in the foot.
The Native Americans are putting a little clinic down there where we got booted out of. Maybe.
They bought the space, yeah.
Maybe we could help them some way or other, or could I ask Greg a question? Oh, he got off. Not related.
He's starting to scare, but he's still.
He's right directly across the street from the Air Force Academy, across from Highway 25. He's one side, they're on the other. Do you know, have you heard anything about what those drones in New Jersey are? I just thought.
Can't help you there, but I can see the Air Force Academy.
Or they,
San Diego?
We were in Temecula last night.
Oh, wow.
I'll be darned.
Those were mine, sorry.
Everyone will sleep better tonight.
thanks anyway.
You know, Ross, to just follow up with what Tim said about the productivity, it really comes down to a decision on, because you cannot see as many people in the mobile clinic as you can. It's significantly less. So we're at the point of deciding, well, do we have a provider work in the clinic and see up to, 28 to 30 patients in a day, or do we put them out on the mobile clinic and they can see 12 or 14.
Okay.
So the amount of impact that we can have is much less, unfortunately. So,
Well, should we consider selling it then?
So it's a school district that should have bought it to start.
I actually have someone who might be interested in that.
So,
So that's what I say. We'll talk about that exec team and see.
I think it's something you guys ought to consider
Yeah.
and bring it back to the board.
yeah, fortunately, with all of the COVID vaccines that we did, the huge volume that we had with that, and with the increased impact that we had in the clinic from our patient volume, it was significant. So the mobile clinic definitely, I think paid for itself at that time, but we do need to address realities of how much we can actually utilize that. It's not a problem with just us. It's even the county is unable to utilize their mobile clinic because of staffing. It's the same thing that they have.
Yeah. All right. Thank you, Greg.
You bet.
John, this is great. It's already working.
That's what we wanted to do. Good.
Any other questions for John on this report? No. Catherine, any questions?
Well, it's in process, right? I mean, this is not, what we've got here is not set.
No,
I was looking at those.
no.
We got one, okay.
This one's,
Okay,
this
the other
one's
one, you're gonna do the other
always
one next.
evolving, if you
Okay.
want to make it better. And it's, you got ideas to make it better, I'm all ears.
Okay.
Sorry, Catherine, did you have any questions on that?
That's okay. No, I didn't have any questions. I'd love to see it back in use, but I don't have any questions.
Okay, thank you.
Thank you.
All right, John. Next one, handout.
Product line summary, product line analysis summary. This is something you guys requested and it's something we want to do to just kind of look at our product lines and how they're doing. This is what's kind of in process. The hard part is the allocation between inpatient and outpatient, because you need to allocate the ancillary departments. And I allocated based on the revenues. So whatever percentage of inpatient, I took that amount of expenses and put it to inpatient. Because they're not directly, they're indirect expenses. But they're really not indirect as on this sheet, but they're, lab, radiology, CT, things like that. You need to allocate between inpatient and outpatient. Also, IGT is not reflected here. So that's why it ties to our income statement as of October. But IGT, when we do the audit, when we finish the audit, we're going to make a couple of adjustments and our income is going to go up a little bit because we have not really seen the effects of that yet. And as far as allocating it between departments, that's going to be a little bit more difficult to do. May just put it as one lump sum. But I mean, as you see, some of these departments on their own without non-operating revenue or other revenue are in a loss position.
A lot of them, more than half.
Right. Well, that's a critical access hospital. That's break even.
That's what we get IGT. Yeah.
That's what
Well,
IGT.
And the other thing too, I mean, take it like a pharmacy, for example, I mean, it's showing a $200,000 loss.
Right.
The issue is there, we don't see the impact of 340B there yet.
Right.
That,
And
that's a $600,000 a year
I
issue.
think,
So that's what we're being told.
right. We're in the process of evaluating 340B right now, kind of looking at what it is. We're going transaction by transaction to make sure we're getting the correct price and we're getting paid the correct amount. And we're going to probably hire a person part-time to go through every transaction. Tim and I have spoken about this already. And Michael Brazy, who is the 340B coordinator, he thinks that's a really good idea. He's been looking at some of them. He's kind of got an idea of what's going on, but I think we really need to dig down and see that our processes are correct. And then once that's done, it's probably a part-time position, once for a month or so. And once that's done, then we know we're doing the right track. We can see what the real effect of 340B is. Like Tim said, we think it's $600,000, maybe more now with our prescriptions going up like that. But that's a big jump, and we want to make sure that we're really taking advantage of it, and Cardinal's not taking advantage of us.
They're gonna
That's-
go up
that's the
even
main thing.
more because the 2,000 maximum out of pocket next year. This past year was 7,000. And so this year it's 2,000. So more people will be getting drugs.
More drugs, that's good. Good
It's,
for us.
The measuring, you're measuring according to the budget.
Yeah.
Where do you get the budget from?
Budget of what?
Of everything.
Oh, the budget?
Yeah,
That's what I come up with, we all come up
yeah,
with that.
from,
Historically, we built on the prior years.
prior years. Well, you keep going downhill and you keep looking good going downhill. It's pretty stupid. You should have like going on full cylinder, what the potential is.
That's not a budget. That's.
Well, I know, but it's what we should be making. The budget, you just keep going down on it.
No.
Next year, we keep losing money, and so you set the budget on what we're losing.
They increased the budget.
Yeah, that's not true. Yeah, we're increasing, especially revenues are increasing. Expenses are going to increase because of.
Okay,
inflation.
an example, SNP,
Yes,
it's gone down from a census of 65 average down to 47. And everything goes down with it, the expectations are less. Because the prior year's budget was less.
there's got to be some realism in the
But
budget.
I know, but there's got to be there's got to be a picture of what it could be. You're looking at,
That's a different document. What it should be would be a pro forma income statement. I can do that too, no problem.
The issue is we know where the thresholds are for that unit over there, and that volume has been coming up. We were down around 35 for quite a while. And so then we gradually got that back up. We're at 48 right now consistently. And so forth, she's got.
okay, where's that at? Where is that?
I did a pro forma for the SNF, remember I did that. I'm going you're at 50, 45, 50, 55, and
Okay,
50.
you'll actually send us in the works. I'll look at it some more. We're talking.
How would you, I mean, yeah, I can do whatever you like to see.
Gina, I have to agree with you again. Sorry. I understand your point. I don't think this is the tool for what you're looking for.
Well, we need it.
but we need the other thing.
I could
Right,
create it to you
right,
like that if you
right,
want.
right.
I mean, if
Yes.
you want something like
Yeah,
that.
we need
I-
to
it's
know
not a
what
problem.
we can be doing, not that we're keep falling and catching ourselves.
See what you're saying. I agree with you there.
Like goals is what we were trying to
That's
say,
what
like.
Yeah,
I
yeah.
mean, it's
Here's what we want to
it's a wish list, basically, is what it
Would be
is.
sort of like a goal. It's what we're potentially can be.
Right,
Right now, we're here and where are
Right.
we gonna be?
How do we get to that goal?
how do we,
Multiple
right,
stair.
and we'd have to make some assumptions, of course, I mean, that's kind of the pro.
Terry's process improvement.
I don't know if that's the right committee for that.
That works.
He knows kind of financial goals.
John, what's the last column, the adjusted patient days?
Oh, that's just for the, up on top there, it really, that's the totals.
Okay,
Just the patient days, or what you do is you take your patient days and you do the ratio between inpatient and outpatient, multiplied by that, and that's how you get adjusted patient.
okay.
days.
But this is basically just the total of this chart.
Right,
Okay.
yeah, and that ties directly to our financial statements that we have in
Okay.
October.
That loss in the retail pharmacy is definitely something to consider when we're talking about $1 million building.
Yeah, but it's also, yeah, no 340B.
But it's 1 month too. It's just a snapshot.
No,
No,
this
it's
is
your
your
So far.
Oh, is it the
It's
whole
4
year?
4 months, yes, this is.
Oh, okay, all right.
This is your 4
This is
months.
gonna be done every month. We'll add another month.
Yes.
Okay.
Go on throughout.
I'll update this every month.
So the IGT, you'll be able to add then another row at the bottom or something to show.
What I'll probably do is just put it in a lump sum in the total, most likely. If you want to see it by department, we could probably do that and see what the IGT, most of it's going to be in the SNP department, actually.
Yeah.
A lot of it, maybe not most, but a lot of it will be in the SNP.
Well, hopefully, ED visits, clinic visits, outpatient visits, med surge. Seems like that IGT covers all of those, doesn't it?
It does.
So one thing that kind of struck out for me, and I appreciate you doing this again, because this is one of my, or was one of my favorite reports when.
I'll do it every month, yeah, we'll have it every month.
But when Chet was here, he always used to gripe all the time, med surge, but I see here, if I'm reading it correctly, a net profit of 200,000. So what's changed in that particular department compared to like prior years where there was always a loss?
You may have allocated.
Or just
That's different. Yeah, that's why I need to look at it a little closely. I mean, the department didn't change. It's just maybe the way I allocated it.
Oh, okay.
And I maybe see a little, but like I said, that's an evolving process right now. And I'm trying to figure out.
The fact that Ross has agreed with me about 3 times, Ross, is there any, can I ask you a question? And I'll pay for it.
I'm as shocked
Okay.
as you.
If I have to have a PARD, do I have to do it before the 20th of January?
It's an interesting question. It's all right. Gene, I've already ordered a plaque that has the two of you holding hands on it. I don't know how this happened.
We'll put it right.
Some flowers.
Is there any other things that you guys want to see on here that are not? on
No,
here?
I think, I'm sorry.
Go ahead,
I just have more questions.
Go ahead, Rob.
Oh, go ahead.
The overhead expenses, what goes into that? We have $3 million basically in overhead expenses. What is it?
Finance, HR,
Non-revenue producing
yeah, all, exactly, housekeeping,
Nursing.
nurse, no, not nursing. Yeah,
Okay.
non-revenue.
All the
departments.
support infrastructure.
Right, right,
How do you allocate it?
based it on revenues,
Okay,
percent of revenue.
percent of revenue, whatever the percent of revenue that department is total.
Like skilled nursing, the propane. We spend $20,000 every 2 months or is it a month?
Some of that may be direct expense though.
No, there, it's almost about 18,000 a month.
Yeah, so they're about 60 or 70% of the hospital, the Smith. So are you allocating 67% of the propane to them?
I have not, I'll have to look into that. That may be going directly to them. If it's paid by that department, it'll be direct expense.
Yeah.
Well, no, it's
Propane
not.
would be spread probably.
Okay, but that's what I'm
Everybody's
talking-
paid for out of my
You know,
That's, I'll start looking at different ways to allocate some of those expenses and that'll be one of, that's a good point though.
because the overhead, the more patients we got there, we should be making more money because the overhead's staying the same, the fixed overhead. But I know we've got extra nurses and things like that, and extra supplies when we get more
Where are
patients.
we hiding them?
No, yeah, but gee, what we said on the pro forma, the expenses aren't gonna go up a step until we get up to 60 patients.
Well, the overhead's gonna stay the same,
Right.
they're fixed.
Right.
The more nurses, more supplies are gonna go up a little bit.
No, we won't, the nurses will not go up because we have enough nursing right now for till 60 patients.
Well, LVNs we don't, on that side, we need to get some more.
Could be a little,
We have CNAs.
So you yeah,
but basically, the
right.
more patients, the better off we are, once we hit that break even, which we're behind break even, I think. When you look at all the expenses, but anyway, that's different.
Well, yeah, if you said IGT, because
I didn't see this until 2 o'clock today. Did anybody else get these soon?
I got it this morning. I was at a doctor's.
You were able to read that?
Bakersfield. I got it on my phone and I was,
Well, you can expand it.
yeah.
Well, I mean, I didn't really have a lot of time to really look at it.
it's
That was
one,
my fault. John sent it on
No, I'm
Saturday. I
not-
thought there was gonna be changes
Yeah.
to it, but I should have sent it. to
It's fine. It's just,
just, if you have any other questions, just
Yeah,
call me.
let us
I'd be happy
get
to
it.
answer.
let some of it sink in.
And we can put some legal paper and just fold it or whatever.
Put it
If you want to make it bigger, yeah, that's what I couldn't figure out. I couldn't figure out how to make it bigger. I just fill the whole page up.
Yeah.
I think it's really, I think it's really good. It's a really good work.
I like that idea.
I think it's true.
Scott has an idea, but I think that Dean and Bob ought to get together, they're agreeing so much, they should have a cup of coffee and go over it.
Are we more unified after the election? Is that what's happening now?
I don't think it has anything to do with it.
John, you had a question?
No, I was just gonna say, thank you, John, for putting this together. I think it's a good tool. It's a good starting point for us as a board to kind of watch it month by month, the different product lines. And it's good to see this again and go over it.
It'll be interesting to see if our volumes start going up, how it changes. That's what I really want to see. When, not if, when. Kevin.
Catherine, you have any questions for John?
No, but I do like the report when I went through it. I went through it a couple times, once on the plane, but it's, I like seeing the different things that you are reporting to us. I know we ask a lot of you, but your performance has been really appreciated. So thank you for that.
Thank you. You're welcome.
Gene, any other questions?
No, I just like to see more money here.
Me too.
So would we. And we will have, like IGT will be coming in. We actually have a delayed payment. They delayed the payment on 1.2 million that we're supposed to pay right now. That's not going to be, they don't know when they screwed up their numbers. So they drew it back a little bit, but we'll have our $4 million coming in probably February or so. That's matching. We'll have 80, but we put 4 million in.
Yeah.
Ross, any additional questions?
No, thank you.
John? Thank you, John.
Welcome.
Okay. H4, building planning meeting discussion, Shirley.
Thank you. So with the building and planning meeting last time, the last few times, it's been, Bob's presentation, which it could be written. Don't have to take his time. He's already taken his time to do the written report. And all the invoices we approve as part of that, I don't know if that's really necessary. Those go to finance or they could just be paid by staff. There hasn't been an error that we've caught in it. So it seems kind of like a pointless exercise at this point. I just wonder, since we're not planning on building anything other than perhaps the pharmacy, is this a committee that we need to continue with? Is it something that we can drop and just bring those matters to this board meeting?
We could, I would maybe just, like I said, put this on hold for a while. Like I said, we certainly, like I said, John and I talked about that, but, the thought was finance. We could bring some of these things to, or Bob and I talked about it as well. Until we get into the construction.
Right.
Then obviously there's a purpose to be here regularly.
Right.
Because there's gonna be a lot more activity.
Just doesn't seem at this point,
Yeah.
it serves much of a purpose.
Yeah.
Other than, we use it
It's been a
sometimes
help
as a
from-
special board meeting.
Right. It's been a help,
but
right, that didn't get through or didn't get in time for the board meeting and stuff like that. Yeah, it's been a plus for that, so. But yeah.
just, we can't talk about it because it wasn't agendized. That's why I asked it to be on this agenda, so we could get board members' feedback on what do you guys think?
But I think we need to make a decision. Can we move forward or can't we move forward? That makes a big difference whether or not we have it or not.
Oh, you mean with the building project?
Right. I mean, can we afford it? If we could get John to go with the guys we get money from and see if we could borrow, I don't think we can borrow, but see if we could borrow enough. Either way, if we get the money from FEMA or not. We gotta figure out which way, if we can move forward, how we can do it.
There's options, Gene. I mean, clearly the best option for us is FEMA. In light of that, if that were not to come through, in talking with Gary, our financial analyst that we have, that's done some other things, he says there are certain opportunities that we can go back and do some federal funding for some of these things. I mean, that we pay back over time or whatever.
Let's see where we're at.
Yeah, but that's the whole point. It's like I said, FEMA's our best option. And so we just got to wait that out right now.
Wait it out for how long? 10 years?
And also, Gene, the way that I'm understanding what Ross is saying, it's not that we're eliminating, might be eliminating that particular meeting, but anything that's important at any time that's coming to this meeting will still be in front of us to make the decision on. We're not saying it's going away. At least that's what I'm understanding.
Yeah, not at all.
I'm just saying that we don't have to meet together to discuss that one item, but that anytime we have anything of importance, it'll be brought to the board for us to decide.
Okay. But
That's the way I understand.
time after time, whenever I say, let's do it, they'll say, let's put it on, it would be better off, say it'd be a shorter board meeting. We put it on the
Well,
other
it won't be
meeting.
shorter.
And
The
so,
way we do it, it should get
you know,
more.
so we can't not do something because it'll make the board meeting longer.
It can.
Okay. Well,
Need to get done, need to get done. We'll bring it,
I'm not sure we should all think about it. Do we need to make a decision right now?
No.
We could,
I just wanted the opportunity to be able to talk to you about it.
yeah, but now it should never have been there all along to start with because it wasn't really necessary all the time. However, when do we stop it now that it's been the way it is? And so,
Yeah, that's why I wanted to bring it up for discussion and maybe like Tim was suggesting, we put it on hold for the next 3 or 4 months until we get the green light on the construction project and then
well, we
start
don't
scheduling.
put it on hold and wait until it's like the frog that, you know what they'll do, you put him in the frying pan, you turn the heat on low and he won't move, he'll sit there until he's cooked. And
I won't
Is that
do
what-
that to you, Gene. You're not on oxygen.
is that what we're gonna do?
No, I was just trying to free up
I know.
our time and staff's time on, make sure we're making the best use of our time.
Scott.
So you run a joint committee/special board meeting.
Right.
So are you talking about eliminating both of those?
Yeah.
Or just the special board meeting and have building and planning continue to meet to discuss facilities?
Certainly one option.
Because you
Make
have
it a
committee
committee.
members.
Yeah,
You can make it a
just a
committee. And then bring
Stop
what committee.
identifying committee members when the board made the decision that they wanted all board members to be able to participate. That's why we started posting it as a special. We do not have committee members assigned to that committee any longer.
So that technically it's not even a committee.
Yes.
Right? You should just call it a special board meeting in that case. But if you wanted, and I don't know if Bob and Tim want it, but if you wanted a committee to address
Go back
facilities
to the
issues,
committee.
Just go as a regular committee that makes its recommendations to the full board.
Yeah, that doesn't sound like a bad, but let's think about it, but that sounds like it'd be a
Certainly
good
not.
idea.
I think until this thing becomes active and not stagnant like we're at now, it's some of what's done.
Why are we stagnant? Why are?
We're waiting for money.
We're waiting for the money.
We're
The only
backing
reason.
up.
It's the only reason.
You could get a loan, though. It's just
Gene.
very high right now, too.
Hey, Gene, the advantages, this is why we have discussions.
Well, and if we were to proceed, then of course that FEMA's done. Because with a shovel in the ground,
It's
there's no
not,
chance.
But we need to look at,
I understand.
if we get the FEMA money, it's about half of what we need. Can we even get the other 20 million or whatever it is?
Yeah, I know we still need to get GC in place. It gives us true numbers on where we stand right now.
You said you've
We
been
chose-
talking,
Chose not to put it out to bid until we know whether we have the money.
Correct.
Correct.
you said you've been talking to somebody about money.
Gary Hicks.
But there has been discussion with Gary Hicks and there
Yeah.
are options.
So let me just say, this is not a discussion about financing the project.
No.
It's just
Right,
whether or not
right,
the committee will
okay,
continue.
okay,
Sharing information.
All right. Okay.
Yeah.
It's a whole other topic.
Right.
Okay, but Russ, we either need to make it back to a committee.
Yeah.
Which wouldn't be the end of the world.
Yeah.
And, then it come here, so,
Whatever
but,
works.
but let's maybe think about it next month, vote on it.
That's
or
fine.
talk-
Whatever you guys want to do. I just want to bring it up for discussion.
Okay, let's table this till next month. You okay with that, Catherine?
I am okay, but maybe in the beginning, instead of it just going away, maybe if we go quarterly, because then at least what I'm concerned about happening is if we turn it back into a committee, somebody's not going to be happy that they're not on that committee and something was said and they missed it. And then they didn't pick it up when it was issued, discussed at the board meeting. That is a concern. So I know it was switched to this type of meeting, so all 5 could attend, and I think that was before I was elected, because it was already monthly when I came on. But so while everybody's thinking about it, I would think even just going quarterly right now, because I mean, we may get the FEMA money soon or we may not, but at least we're still hearing different things about the projects that are going on, the stuff going on with the acute care in the hospital and, different things. But if it's only quarterly, that cuts out, 2/3 of the meetings, and maybe it would still keep us on track without feeling like we need to start from scratch and, catch up with everything that, we weren't all participating in at the same time. That's just my opinion. I think we could do with or without it. Because it's the Bob show, and I don't mean that in a bad way, but he's the one giving most of the information. And this last meeting, I mean, he was in and out. I mean, it was short because like, Ross says, there's not really anything going on other than just our normal maintenance and improvements with the buildings and stuff. So I am agreeable either way as far as making that decision. So
Catherine, if they went back to the committee, the board would have to approve everything that goes through that committee. So you'd have a chance to discuss it at the board meeting, whatever they decided they wanted to do the two. So
yeah, but Jean, would that make the board meeting longer? Just
yes,
kidding.
So let me say this. In January, you have your annual organizational meeting.
Yes.
Where you elect officers and you appoint committees. What Catherine is talking about and what your practice has been is having a special board meeting. You can call a special board meeting at any time. All you have to do is give 24 hours notice and you can have that meeting. So let's say something happens with FEMA, the funding comes through, call a special board meeting, you all get together and you discuss where you want to go. That is separate and distinct from a building and planning committee, which is dealing with ongoing facility issues. So you're going to talk about this in January anyway, next meeting. So, maybe you want to think, do you want to have a building and planning committee at all? And just remember that when the 5 of you are together, it's not a committee meeting, it's a special board meeting. Correct.
and to do it quarterly, things can,
Excuse
at
me.
any rate.
Bob, you had a statement?
My only kind of question or input to this is you had wanted to see all the invoices. So that has to happen either then at the board meeting, if we're only going to do it once a quarter, or if it's a committee.
They could still go to finance committee and come to the board as part of the consent agenda.
Right, because my only concern is that the contractor is already not very happy with the length of time it takes to get paid, because they usually end up getting the invoices into me too late for a building and planning, so then it has to wait a month for that, and then it goes to finance or to
We
finance.
can
but to
discuss that
accounting
next month.
to be paid, and that takes several weeks. And so they're not real happy with the payment because of having to wait almost sometimes 2 to 3 months.
Understand. We can make that decision next month when we
Yes.
turn it into a.
I just wanted to bring it up.
Thank
Yeah,
you.
those are things, discussions you can have with the contractor too, saying, hey, you gotta have your invoice in by this date. And put it-
Oh, they know, but
But if they don't do it, that's on them.
yeah,
Okay.
they know. And that's what I informed them of. You missed the deadline by 3 days, so it has to wait a month to go for.
Now, while we're talking about this, Heidi, I would like to request at the board meeting next month that we discuss exactly what he just said we're not discussing. That is, what are we gonna do with the construction? Are we gonna move forward or backward? Let's discuss it.
Let's put it on the agenda.
Yeah. I can't get it on the agenda because it's better at the board meeting or at the other meeting.
Then let's get it on the agenda.
Yeah, let's get on this next board meeting.
Which.
So plan B, if FEMA funding fails.
Let's have it
Right.
planned.
Either way, if it comes in, this is what we need borrowed, this is what we need to do. If it doesn't, this is how we need to do it.
Okay.
And if we need to go to community again, which I think with the AI and the possibility, I hate to spend.
We
the
can
money.
save that for the discussion.
Oh, yeah, okay.
All right. So let's, like I said, we'll table H4 to next month and we'll expand on the conversation with the project. Okay. All right, H5, committee meeting dates. Miss Catherine, this one's on you, dear.
Yeah, I just know that with the holidays, Christmas coming, I just had concerns if anybody was going to be in town, out of town, family, if the meeting dates needed to be changed or times to help accommodate anybody that may have concerns and those meetings that are coming up towards the end of the month.
What are the dates?
The dates that they would normally fall on would be the 23rd, 24th, and 25th.
Well, that would be good for me.
No problem.
But I think that we can get away with not doing a building and planning meeting.
Correct.
And so what if we did board P&P and finance committee both on the 30th? It would give everybody time to get their reports in with closing out the month and everything. We would still have time to get the stuff processed and onto the board meeting agenda for the following month. And so we would just do those 2 committee meetings on the 30th, 9 a.m. and 1 p.m.
I don't have an issue with that.
And if we had any construction invoices that needed to go, we could take them to finance committee for discussion.
Which I do. That's what
Okay.
I wanted to bring up. This is gonna really delay the payment for the current invoices. But not by a whole lot if we go to finance on the 30th.
It goes to finance.
Will it be okay on the 30th?
Well, yeah, but then if it's the 30th, then that's finance, but it still has to go to the following month's board meeting, 2 weeks, 3 weeks later.
Second Thursday. 2 weeks later. Yeah, it'll be 2 weeks later.
It would
Would
be
it,
on the
though?
9th.
I'll just inform them that the payments.
Can we,
Are in.
and all the board members are here, can we make an exception? Say,
That if
it's
finance
delegated to
approves-
staff, pay the damn invoice.
It's not a lot. It's.
Yeah, just pay it. It doesn't need board approval.
Right.
So what amount? So what amount, Russ?
What if-
What's that?
So what amount?
The pending ones that he has right now.
What's the?
I don't know at the top of those off the top of my head, but there are a few $1,000.
Yeah, it's,
We've looked at, I don't know how many invoices through building and planning.
It never.
Never once have we rejected one or found an error or any problem. Just
We
pay it.
bitched about some of them.
Yeah, we have, but
Sorry, guys, hold on.
Isn't Tim authorized, or John, isn't someone authorized to pay bills that are part of a contract that's already been approved by the board, that is in a board approved budget?
Yep.
Yeah, so you don't even need, yeah, so they can just pay it.
Yeah, right, just, and they'll still show up and we can
That's
talk about it.
I believe I currently have.
we can do that.
Yeah, okay. I mean, I can bring them to administration. We can get the appropriate signatures on the sheets and.
We'll still see them.
We'll see.
yeah,
And bring them out.
Yeah.
I kind of like that idea. Just go ahead and pay them under your authority and then report to the board what you did.
Okay.
So what about Bob's project update? Would you guys still want to see one of those at the January board meeting?
I think it needs to be included in the packet monthly.
Yes.
Like
I'm fine with that.
What's that?
Like our reports are.
Yeah,
That's correct.
Yeah,
Put in.
absolutely.
Yes.
packet. You can always pull them.
And then unless the project starts, it's gonna be short and sweet anyway.
Yeah. Catherine, you agree with that?
I totally agree with that.
Thank you.
Totally.
And if something comes up, hey, come talk to us.
See what breaks next week.
Yeah.
John?
Do we have to take action on this?
No, it's an action item.
It's an action item for the dates of the 30th.
Okay.
But you don't have to vote scheduling a meeting.
All right.
I might participate remotely on the 30th.
Should send me your address.
All right. Me too.
To the valid reason, close it.
So,
I guess with that said, we got director's comments. Miss Catherine, do you have anything?
I do not, other than, I just appreciate the vote and the way that it went and that we are, all continued to be members. I think we're just starting to be, a cohesive unit and working towards the same goals, and I appreciate that.
Thank you. Mr. Parks?
I just hope that we can all hold hands and do the Trump hands together.
You too. I'm gonna be sitting that one out.
I don't see him off.
Mr. Blake?
just, Merry Christmas to everybody and, congratulations to you as being selected for Man of the Year.
Yeah, thanks.
I know the guy that
He's a boy.
I know the guy that was man of the year last year, and it was
Yeah. It was pretty good.
He's ready to give it up.
yeah.
That's all I have.
Shelley?
Just wanted to congratulate you three for being reelected. I think that it keeps the district going on the right path by putting the incumbents back in. And I think that's a really good thing for the community, and I'm glad the members of the community selected you three. And a very Merry Christmas and Happy New Year to all of you. Appreciate working with all of you. Amazed every day at what the staff here does. And keep it going. Keep up the great work. Thank you all.
Thank you.
Thank you, Ross. Thank you for your campaigning.
Gary, can I ask you a question?
Sir?
Can you use that program while we still have it to blank out the part where we agreed?
I do it every time. It goes without saying.
Oh, okay.
He has AI working on it.
We've got to keep the drama up or we'll lose our reach.
I actually add a little argument in there just to keep, it brings up viewership, so.
At least John's not climbing over the table this time. All right, guys, I just want to say we have a great team. I'm glad we're all together. With that said,
Closed session.
closed session,
So we
sir.
don't have updates for any of the litigation. So I don't have anything to report, so it's just CEO performance evaluation today. Tim and Heidi, are you in agreement?
Yep.
All right, we are back in closed session. The board did the CEO performance evaluation. No other action was taken. No other items were discussed. And we are adjourned. Everyone have a great day. Be safe.
Great holidays.
Happy holidays.
Yep. Thanks, everybody.
Thank you, sir.